Aurora Brown and intersectional psychology acknowledge the traditional owners and custodians of country throughout South Africa and their connections to land, water, and community. We pay our respects to their elders past and present, and extend that respect to all Indigenous people listening today. Hello listeners, this is an extra special Patreon exclusive episode featuring Dr. Anastacia Tomson. You might recognize her from the first episode we did in this series on gender-affirming healthcare and the health of trans and gender-diverse people. I've decided to unlock this episode and make it available here on the main feed because, well, firstly, this is excellent information that should be out there in the world. And secondly, it is a little taste of the kind of bonus content you can expect when you join the Patreon. So enjoy this bonus content from my interview with Dr. Anastacia Tomson. Intersectional Psychology, Season 3, Episode 1. The Truth About Gender-Affirming Healthcare, with special guest Dr. Anastacia Tomson. Hello and welcome back to Intersectional Psychology, the podcast that explores psychology's role in promoting social justice. I'm your host, Aurora Brown. I'm a registered counsellor in Cape Town, South Africa. Thank you for being here. Dr. Anastacia Tomson is a medical doctor, an author, and a fierce advocate for LGBTQIA+ and human rights. She was the lead author of the inaugural and still the most comprehensive guideline for gender-affirming healthcare in South Africa. Her lived experience as a queer, transgender woman who transitioned within South Africa's healthcare system, combined with her years of clinical work supporting others on their own journeys, gives her a rare and invaluable perspective. Her work is driven by a deep well of compassion and a fierce commitment to justice. Anastacia, welcome to the podcast.
Hi, it's my pleasure and privilege to have this conversation with you today, Aurora.
This episode is for educational purposes only and is not intended to be a substitute for professional health advice, diagnosis, or treatment. Aurora Brown and Anastacia Tomson are not able to answer specific health questions about individual situations. Always seek the advice of your health provider with any questions you may have regarding your health care and health conditions. Never disregard professional medical advice or delay in seeking it because of something you have heard or seen on this podcast. If you think you need immediate assistance, please call your local emergency number or any mental health crisis hotline. The Truth About the Access to Gender-Affirming Healthcare, Part 2. Now, you mentioned when we were talking about values, the importance of the client being able to make the decision about gender-affirming healthcare for themselves. In South Africa, the National Health Act stipulates that a health service may not be provided to a user without the user's informed consent. So it is already illegal to give anyone any form of healthcare without making sure that they understand what the healthcare does, how it works, and what the potential consequences are. And these guidelines that we're talking about today are very clear about the necessity of informed consent. You literally devoted an entire chapter to that topic. So, what does informed consent mean in the context of gender-affirming healthcare?
I think we've, to a large extent, already almost answered this question, but it means that you, as the patient or the client, depending on your preference, would need to be in a position where, so there's two components. The one is the informed. That means that you have the information and having the information is shorthand. It's not enough. It's shorthand for, it means that not only do you have the information, but that you have understood the information, that it makes sense to you, that you have had any questions that you might have been addressed or answered, and that you're satisfied that that there are no gaps or deficits in that. And it means that I'm satisfied as a practitioner that you've received the information, you've been able to understand it. These are the important things. And then the consent aspect is just, this is obviously informed not just by ethics or institutional policy, but also by legislation, is, are you capable of making a decision? And capable of making a decision means that you are of legal age according to your local laws, or your national, whatever it is, wherever you are in the world. And it means that you are not impaired in any way. So you are not under the influence of substances, you are not intoxicated, you are not actively psychotic or have a condition that renders your judgment or your reality testing impaired. That you're conscious is also part of consent, because unconscious people can't give consent. So, this is really what we mean when we say informed consent. And kind of most importantly, as I mentioned earlier, it requires that the decision is actually made by the patient. And then the other thing that I want to clarify is just that we often conceptualize informed consent as being the singular point in time, that the patient gives consent, gave consent, whatever we documented. But informed consent is an ongoing process. I might have answered all your questions today, and the next time I see you, you might have more questions. This is part of informed consent. So it's longitudinal is really what I'm getting at.
Why gender-affirming healthcare is primary healthcare. In South Africa, gender-affirming healthcare is considered primary healthcare, so theoretically it should be available from all community clinics and GPs. But unfortunately, that is not the case right now. Why is it so important for gender-affirming healthcare to be available as primary care, as opposed to only from specialists?
Yeah, so, just to sort of clarify the situation where it is at the moment, is just to say that the guidelines do say that this should be primary care, 100%, absolutely. In terms of like public healthcare policy, so gender-affirming healthcare and the hormonal therapy are listed in South Africa's EDL or EML, our essential medicines list, which is a formulary that talks about treatment for which conditions are available at which level of care and so on. And they are listed, but they are listed at the moment at the tertiary level. So just to recognize that there is that disconnect, and we hope that given the guidance of the guidelines that this would become eventually more accessible. And the reason it's important is just that primary care is much easier to reach than tertiary level care. If you as a trans person, go wander into the reception area at GAHC and you say, look, I really want to get onto hormones, you are going to have a very tough time of it being, even making it past the security guard at the door. So these services are very strictly gate capped. They are geographically bound. So, you might live in an area where there is no one is willing to prescribe for you at tertiary level, even though it's listed in the EML. And you might travel to a hospital that is technically you live outside of its catchment area. And you'll now be in this back and forth where you go to the one facility and they say, sorry, you're not our patient because you live here. And you'll go back there and they'll say, well, we don't know how to treat you. You must go to this hospital, which is the one that bounced you back in the first instance. So these are the kind of difficulties that you encounter. Primary care would really enable people to have far fewer hurdles to jump over in terms of trying to access care. And I think it would also have the benefit if we were to offer these services in primary care or at a primary care level much more widely. I think it would, by necessity, mean that healthcare providers in general are more knowledgeable and more skilled in interacting with trans folk. And, this becomes important when you realize that, well, hormones are great, gender-affirming care is wonderful, but people also have other healthcare needs. You could be consulting for your diabetes or your high blood pressure or your stubbed toe, whatever it is. And unfortunately, but so often trans identity comes into this. It's, I don't know if you or any of your audience will have heard of trans broken arm syndrome. But, essentially this means that when a transgender person shows up at a casualty department or an EC with a broken arm, that the doctor who sees them will say, oh yeah, this fracture is because of the hormones. And it means that it's a shorthand way of saying that just about every medical condition that you could have is often attributed to the hormones, even if there's something else going on. And, I think that wider access at primary care would, have the benefit of sort of destigmatizing this and letting people understand that hormone therapy isn't this crazy dangerous thing that we only do on the fringes of society and that has all of these horrible effects like breaking people's arms and so on. And that people who actually need to access care and for whatever reason will now be able to. And I think that I think the benefit of that would be tremendous. It's scary to go and try and access healthcare services as a trans person, even in the private sector. If it's a clinic or a doctor that you haven't seen before, that is some scary stuff. And I feel like we need to demilitarize that experience.
I'm just looking at that little trans doggy walking there behind you.
It's
Very
not
cute.
her. Sweet little girl. She's been taking a nap, so
Oh,
yeah, she's probably just kind of stretching out.
Hello, this is future Aurora jumping in with a little content note. For those listening, the reason I said little trans doggy is that Anastasia's dog is wearing a beautiful, cozy jersey in the gorgeous pink and blue colors of the trans pride flag. Obviously, I am not really calling the dog transgender. I don't know how they identify. That is for them to say or to bark. I'm not imposing gender ideology on anyone, anything. Okay, let's get back to Anastacia. Psychosocial support for transgender and gender diverse people. In the the next episode, we're talking to a mental health care provider about psychological care for TGD people. So we won't go into detail about that right now. But the chapter on psychosocial support does summarize the role of mental health in a TGD person's journey. What should we know about that?
I think what we should know about that is just that mental health care needs to be seen as supportive rather than as a prerequisite. So it's not you need to have X number of therapies before you can transition, which is one of these myths, one of these misinformations that is rooted in very, very dated and, let me say, obsolete clinical practice. And I think we have to recognize that, there's still a lot of stigma around it because gender incongruence and gender dysphoria and gender identity disorder and listings in the DSM and all of these things that have kind of created this bond or this link between mental health and gender identity. And it's not to say that someone who is trans can't have mental health conditions. And it's also not to say that we don't necessarily have higher rates of mental health conditions. Try living in a world where everyone hates you and you're not allowed to use the bathroom and people are trying to look inside your pants even when you check out at the grocery store. Do all of that and try not having depression with it. I dare you. You can't. So of course there are higher rates of coexisting mental health conditions, as is true with any minority group, as is true with any group that is marginalized or persecuted or subject to greater degrees of trauma. If you send soldiers off into war, they will have a much higher incidence of PTSD than the general population. That's kind of obvious. But I think what's important for us is really, again, just to kind of address that stigma and to recognize that mental health care should be made available to people. It should play a supportive role. Again, it should be longitudinal. Maybe I don't need it now, but when I move into a new workplace and that workplace is a little bit more bigoted than the one that I'm currently in, maybe now you do need that sort of that additional support. So I think that these are some of the ideas that we really need to start considering. Is just that we are complex entities as human beings, and there are many aspects to our physicality, our identity, our psyche, and so on. And I think just like if you had a trans patient who had high blood pressure, you would be offering them support for high blood pressure, and perhaps their blood pressure is fine at the moment. But, you might say to them, okay, so, if you do need the support of a dietitian, you can come back to us, you know where to find us. We will happily facilitate this for you. I don't think it should be any different in terms of mental health care. So, what I do with a lot of my patients, I don't require them to have a therapist or be in therapy or to present me with a certificate that they passed their 6 months of therapy and now they can go on their hormones. But I do ask if they have a therapist or if they've ever had a therapist in the past. And I try to get an understanding of, was that a good relationship? Is it a bad relationship? If you needed a therapist, would you go to the same person or would you seek a new one? So that we know that we've built a support network and a bit of a safety net for someone should they need it. Being trans doesn't make you mentally unwell. And, there's so much stigma around this language as well. But it does mean that you have to navigate a transphobic world that often requires, or that is made so much more possible if you have better support in a very holistic sense, and mental health care forms part of that.
The truth about gender-affirming healthcare for non-binary people. We haven't spoken much about non-binary patients yet. What should we know about hormone therapy and non-binary people?
I think the first thing that you need to know is that non-binary people can access hormone therapy. They might want to access hormone therapy. They're not obligated to want hormone therapy and they're not obligated to access it. So I think that's important. And then the other thing that's important is just to recognize that we aren't the experts, we as the clinicians. The expert on how that body works and how it feels to live in it is the person themselves. So no two hormone therapy regimens for a non-binary person will necessarily look exactly the same, and that's okay. We need to ensure that what we are doing is scientifically rational and medically safe and sound, that we're not doing absolutely ridiculous things beyond the limits of physiology, which I think we've already discussed. But we also have to ask ourselves, well, what is the goal? Why are we doing hormone therapy? What is the purpose of giving this patient hormone therapy? And I often remind my patients that this goal is your life should be better with hormone therapy than it was without it. I can't decide what constitutes better, what constitutes not better. You are going to be the judge of it. So these are the things that I think we should bear in mind, is just that hormone therapy for non-binary folks definitely is a thing, not mandatory, often necessary, but not always, and that we are not the experts when it comes to this. It's always something that I will counsel my patients, and I'll say, look, we don't know necessarily. There isn't a huge body of published data. It's hard enough to find studies on binary trans folk. Try finding studies on non-binary trans folk, and then try figuring out how you can sort them into statistically meaningful groups and so on in order to draw any conclusions. It's very, very difficult. So, we'll always have a conversation around individual goals, expectations, risks, etc. And we'll plan as to how we're gonna manage this journey together. So again, that longitudinal relationship is coming into it, very important.
Thank you. The truth about trans and gender diverse people in sports. You mentioned that there are natural levels of both testosterone and estrogen in all people. Now, sometimes these quote-unquote standard levels of hormones are used to judge who should be able to participate in which sports. What are some of the other considerations around TGD people in sport, and how do they impact on cis sports people?
So I can talk for a long time on this, and there's a couple of things that I kind of just want to say up front. The first is just that there's an intense amount of paranoia around this, and I will again go and look through the records to try and see how many world championships have been won by trans people with the aid of their hormones or whatever, and it's zero. So that's the first thing, is just that this threat is blown way out of proportion. The second thing that I'll say is just that hormone testing and gender verification has a long and gross history in athletic competition, and it would be completely disrespectful and disingenuous to try to have this conversation or answer this question unless we apply an intersectional lens to it and we say, well, look, in what instances has this kind of thing been employed in the past? And it's been employed when a woman is considered to be too fast, too strong, too good for the standards that are set. It's been used when women don't meet the aesthetic standards or ideals of womanhood, i.e. they're not attractive enough to men, and then we start questioning their womanhood. It has been employed when women of color are leading in their fields and are excelling in athletic competition, that we start to question, is this person actually being fair, or do they have an inborn genetic advantage that renders them unfemale enough to compete? And I think that when we consider the majority of competitive sport, what we are doing is we are selecting for not just, but definitely for inborn genetic advantage. I'm not saying Michael Phelps doesn't train very, 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 very hard, but I'm saying that the swimmer next to him could train as hard or twice as hard. And until he has the wingspan of a Michael Phelps, which he doesn't have because that's an inborn genetic advantage, he's never going to win. So, we now need to start categorizing different sporting events based on genetics or based on wingspan or based on, are the categories that we have really that meaningful, and where did they come from? And, a lot of them date back to when we didn't properly understand all of the things that go into sex and gender and so on. It's not been proven that being trans or being on hormone therapy, being on testosterone in the case of AFAB individuals, or having had exposure to testosterone previously for AMAB individuals confers any kind of advantage. And what cis people need to know is just that when we start policing these things and we start trying to enforce these notions that are not born out of any proven or real scientific consideration, but are actually born out of systemic and sociological prejudice, that trans people who are a minority of the population will definitely be affected, but cisgender people who represent a lot more of the population, those that don't fit within these little boxes, will be disproportionately affected. So it's jeopardizing cisgender athletes as well. And if you posit that the reason that you're doing this is to protect cisgender athletes, and you're now sort of actively harming them through your ridiculous and inane and misinformed policies that are built on fear-mongering and MAGA sort of ideology, let's use the word MAGA ideology again, that you are actually working to the detriment of the people that you claim to be protecting. And this is a well, or it should be a well-known principle in how these discriminatory politics work, is by using a scapegoat. In this instance, the scapegoat is trans people, in order to enshrine and protect a power dynamic. And in this case, the power dynamic is in favor of the cisgender, straight, white, rich man. And whatever we can do in order to protect that hierarchy, we are going to do. And it's not, we target it at the trans people, but it's the kind of thing that is going to be to the detriment of anyone. Conversely, when you enact policies that support the well-being of minorities, everyone benefits. And this is the curb cut argument, if you haven't spoken about it already on your podcast at some point. But basically, there was a whole kerfuffle in some other city in the US when people were trying to introduce the idea of, on the pavements, on the curbs, to cut a slope in so that wheelchair users could more easily go up and down. And there was a whole argument about cost versus benefit and whatever, and why should we make concessions for the wheelchair? And it turns out that once they put in the curb cuts and once they put in the ramps, that now moms and tots, people pushing prams, people pushing trolleys, all kinds of people were benefiting from the curb cut. So, conversely to this is just to remember that if we were to actually look at sports and say, well, how do we support trans people engaging in sports in ways that are fair and in ways that are uplifting, we will actually benefit everyone.
Thank you. That was a brilliant answer. The uniqueness of every transition pathway. As we've said, every TGD person's transition is personal. For example, many trans people don't want to have surgery. or don't want to have hormone therapy. What should we know about different transition pathways?
I think that we need to just recognize that there are an almost infinite number of possibilities in terms of what these pathways may look like, and that we shouldn't be subjecting them to any kind of evaluation. We shouldn't be ascribing any kind of value judgment, regardless of what it looks like. So, we have a lot of internalized prejudices, not just against trans folk, not just against queer folk, but we have notions that are ageist, that are sexist, that are ableist, that are racist, that are all kinds of internalized ideas that I think it's very easy to allow these to seep in. And we should really make an active effort to try and dispel these toxic ideas, to nip them in the bud, really, I think is the important thing. So when we look at what does an individual's pathway look like, there are so many reasons that it could be a certain way. And this is another thing that I when I teach medical students, because we're all taught we must take the most comprehensive history available. But taking a history is also a medical procedure, and it can be quite invasive. And I think that we need to recognize that there are some instances where we are tempted to ask people questions, not because it's going to give us any useful information or change our management or change our diagnostic approach, but in order to satisfy our own curiosity, and that should be a warning sign to you. So you should always just vet yourself when you say, all right, let me ask this question about the route that this person has taken in order to get here. Does it serve a purpose? Does it really help to ask someone, why are you only coming for surgery now? Or why did you do this? Or why did you do that? Are we actually doing it for their benefit or for our benefit?
How institutions can support gender transitions. A gender transition isn't confined to the person as a system. It also requires changes to the person in a system and the system in context. The Guideline for Gender-Affirming Healthcare also makes recommendations for institutions to support people's transitions. Can we start with living spaces?
So we definitely can, and I think this is the reason that we recognize that this is important to put it in the guidelines is, number one, because these systems interact, you can't see them in isolation. But number two is that just as there has been no guideline on medical care or surgical care for gender affirmation, there's no guideline for institutional policy, and it's as much needed as the hormonal or the medical guidelines are. So it was important for us to include that. And I think we have to consider every environment. We have to consider, what happens in the home. And to me, that starts at the level of like basic education. It starts with the media that people are exposed to, representation, the way that things are covered in the news, et cetera, et cetera. But, outside of that, it can also apply to communal living spaces, to boarding schools, to dormitories, to all sorts of things. Everything that we navigate, or not everything, but many things that we take for granted in this world are cis-normative and are very much rooted in a binary. And if you fit into that system, it's invisible to you many times because you never have to question it. But for people who don't, fit into that, these things become hugely challenging. So I think certainly we do need to start with living spaces. And I think that when it comes to how do we do it, the conversation needs to be, you have to have people with lived experience at the table having this conversation. You can't look through a lens and study the trans folk and try and determine, oh, this is what they need from your ivory tower. You actually have to invite people to the conversation. You have to get out on the ground and say, well, what is happening in living spaces? Talk to people, find out what are the challenges, find out what could be a solution. and then figure out a way to implement it, which is the job of policymakers, actually.
And how can workplaces support employees' gender transitions?
I mean, they should just pay for surgery, done and dusted. No, I'm kidding, but it would be nice. I think, again, a workplace needs to allow people to have agency over their identity. So, we can't look at your ID document and say, well, your email address has to match your ID document, or the title that we use for you has to match your ID document. We have to really be affirming of identity, respect names, respect pronouns, find ways that we can make it better, find ways that we can make the spaces more inclusive. We've spoken a lot about bathrooms, but, that would be something that would certainly come into it. I think allowing people the space and the support to go through a process that it is a process of change, and sensitizing if necessary. I mean, hopefully it wouldn't be necessary, but if necessary, providing the education, the sensitization to colleagues. This is like an HR thing, is that you have to ensure that people are upskilled with the knowledge and the information that they need to support their transgender colleagues. And, this really is just the start of it. But I think definitely it's a beginning point that needs to be taken into account for the conversation.
Thank you. The truth about voice therapy in gender-affirming healthcare. The final chapter of the guideline discusses voice and communication. I know that my own voice and manner of speaking was a huge source of stress and dysphoria when I first transitioned. And even now that my gender presentation feels more authentic and congruent, if my voice doesn't match who I am or who I'm presenting as, it could immediately out me and draw attention to my trans identity in contexts where it might not feel safe to be out. Our voices are also the only way that we are able to present in some contexts, like on the phone or here on a podcast where people are listening. So, what should we know about voice therapy in gender-affirming healthcare?
It's a very, very important facet, and I think it's an under-recognized one. And I'll share on some of my own personal experiences that way back in the day when I started out with my medical transition, and I was looking for resources, and I went to go see a speech therapist. I was living in Joburg at the time. I went to go see a speech therapist, and I was the first trans patient that she ever treated. And subsequently, she's become a really huge ally and asset to the community. But, she was willing to do the work and to do the research and to collaborate with me and to meet me where I was and to, find ways that she could do better in this space. And I think that was, reflecting on it. I mean, that's obviously a very significant sort of interaction and relationship that I built. And I think that we are still in a position where there are now some speech therapists who are getting better at doing this work and who are maybe even specializing in doing this work. But I think they're few and far between. And I think it's often seen, especially when we think about offering services at the public health level or, in busy clinic environments and so on. I think it's often seen as an afterthought. This is unimportant. But I think we really need to recognize that for a lot of people, it is of huge importance. And, considering the scarcity with which these services are available, for a lot of people, it just becomes a matter of, well, like, this is something that I can't ever have, so I'm going to give up on it, much like the surgery conversation. But this is something that it would not take a vast amount of resources in order to provide these services to people. I mean, you can do it in a group setting. You can do it, you can record it and put it on YouTube as a course. There's so many different ways that we could try to make this more accessible to people. And I think we need to recognize that, this is for many individuals, again, not for everyone, but for many individuals, this is hugely, hugely important. And we don't get to say that it isn't. They're the authority, so we should be listening to them.
I love that. And thank you for sharing your own experience with the speech therapist. I think that speech therapist is a great example of not being scared to work with trans people simply because you don't know or are scared to make a mistake. Most trans people are really happy to work with affirming healthcare providers, even if they don't know everything to start off with. As long as they are willing to accept who you are and do the research. It can be a really affirming experience just to work with someone who sees you. A future for everyone. Is there anything you came to say that you didn't get to say?
I don't think so, but maybe it's just that, we've spoken about a lot of things, and I think we keep coming back to this respect for individual agency and autonomy. And, one thing that came out to me was there was a point at which you said, we're all human and we make mistakes and so on. And I think a very important point for me there is just that as people in this marginalized community, as people who unfortunately become, by necessity, we are very well versed in dealing with malice, with malicious people, is that when a mistake is made in earnest and it's not malicious, I think we're very, very good at identifying that and telling the difference. And, if you are not part of this community, and if you are thinking, well, how do I be a better ally? Be curious, ask the questions. Don't expect trans people to be your Wikipedia. Go do the fucking research on your own first. But, ask the questions. If you mess up, do apologize. Do it with goodness in your heart and with good intentions. And there's really, really nothing to be afraid of. And just to say that, again, a lot of the other kind of concept that keeps coming up for us is just this power dynamic, and especially for healthcare providers, recognizing that there is a power dynamic, and there's a power dynamic because you wield power. And I think just as I can't answer the question for anyone else, what does your transition look like? I can't answer for you, how do I use the power that I have in order to make things better for other people who don't have it as good, or who are marginalized, or who are, for example, trans. You are the only one who can answer that question for yourself. And the first step in answering it for yourself is asking it to yourself. So that's the message that I think I'd like to leave with.
That's beautiful. Thank you. Where can listeners go to find out more about you and your work?
For better or worse, I'm infinitely Googleable. The only trapdoor there is that you have to spell my surname correctly. It doesn't have an H and it doesn't have a P. You'll also find me all over social media under the handle Anaphylaxis. That's got a US at the end, not an IS at the end. Again, it is a very deliberate and intended misspelling. So it's not really a misspelling, but you'll find me all over social. And you can also read more about the work that we do at the practice at myfamily.gp, if you so wish.
Anastacia, thank you so much for your time and your insight and your extraordinary contributions to trans healthcare in South Africa. For anyone listening who thought gender-affirming healthcare was a niche issue or some kind of political hot potato, today made it clear it's healthcare full stop. And if you're still wondering how it affects cis people, maybe it's this. The more we build systems that honor everyone's dignity, the better they work for all of us. This was just the first episode in our series on the health of trans and gender diverse people. In our next installment, we'll be speaking to a mental health professional about what an affirming therapeutic relationship really looks like, and how to tell the difference between support and subtle sabotage. Until then, stay curious, stay compassionate, and please don't believe everything you hear in the WhatsApp groups. Thank you for listening to Intersectional Psychology. Please follow or subscribe to the podcast to get every episode. If you enjoyed this episode, please rate and review Intersectional Psychology in your preferred app. It really helps other people find the podcast. This episode of Intersectional Psychology was researched, written, recorded, and edited by me, Aurora Brown. For a transcript of this episode, please see the link in the show notes on your podcast app or go to intersectionalpsychology.com. You can also check the website or the show notes for a full list of references for this episode. A video of this episode with closed captions is available on youtube.com/@intersectionalpsychology. To support this podcast and get access to bonus content, including additional episodes and interviews, as well as more guided mindfulness sessions, please go to patreon.com/intersectionalpsychology. You can also chat with me on Blue Sky at intersectpsy.bsky.social and Instagram, Facebook, or TikTok at Intersectional Psychology. But mostly Blue Sky. Aurora Brown and Intersectional Psychology are committed to the Cite Black Women praxis. All episodes of Intersectional Psychology are for educational purposes only and are not intended to be a substitute for professional mental health advice, diagnosis, or treatment. I, Aurora Brown, am not able to answer specific questions about individual situations. Always seek the advice of your health provider with any questions you may have regarding a mental health condition. Never disregard professional medical advice or delay in seeking it because of something you have heard or seen on this podcast. If you think you need immediate assistance, please call your local emergency number or any mental health crisis hotline. Everyone deserves good mental health.